Hello everyone, welcome back to my channel, Learn with Professor Janula. If you're new here, don't forget to subscribe and hit the bell icon for notifications. In today's video, we're going to learn about preeclampsia. Let's get started. Students, let us understand preeclampsia in a simple way. Preeclampsia is a problem that happens only during pregnancy. It usually starts after 20 weeks of pregnancy. The main problem here is high blood pressure. That is why we call it a pregnancy-specific hypertensive disorder. Preeclampsia is identified by three important features. First is hypertension, which means the blood pressure becomes high after 20 weeks of pregnancy. Second is proteinuria. This means protein is present in the urine, showing that the kidneys are affected. Third is edema, which means swelling, especially in the face, hands, and feet. This swelling may or may not be present. Sometimes, preeclampsia does not affect only one organ. It can involve many body systems, such as the brain, liver, kidneys, and blood system. This is called systemic involvement. So, in short, preeclampsia is a condition after 20 weeks of pregnancy with high blood pressure, protein in urine, and sometimes swelling, and it can affect the whole body. Now let us look at the incidence of preeclampsia. Preeclampsia occurs in about 5 to 8% of all pregnancies. This means that out of 100 pregnant women, around 5 to 8 women may develop preeclampsia. It is also seen that preeclampsia is more common in prima gravida. Prima gravida means a woman who is pregnant for the first time. So, first-time pregnant women have a higher risk of developing preeclampsia compared to women who have been pregnant before. Now let us understand the etiology or predisposing factors of preeclampsia. Etiology means the causes or risk factors that increase the chance of developing the disease. First is prima gravida. Women who are pregnant for the first time have a higher risk. Next are the extremes of maternal age. Preeclampsia is more common in women who are below 18 years or above 35 years. A family history of preeclampsia is also important. If the mother or sister had preeclampsia, the risk is increased. Multiple pregnancy, such as twins or triplets, increases the workload on the mother's body, so the risk becomes higher. Identiform mole, which is an abnormal pregnancy, is another risk factor. In this condition, the placenta does not develop normally. Instead, it forms many small fluid-filled sacs, which look like a bunch of grapes. Women with diabetes mellitus are more prone to develop preeclampsia. This is because diabetes affects the blood vessels and placental circulation. When blood vessels are already damaged due to high blood sugar levels, the body finds it harder to adapt to the changes of pregnancy. As a result, there is an increased risk of high blood pressure, protein in urine, and poor blood flow to the placenta, which can lead to preeclampsia. Those with chronic hypertension, meaning high blood pressure present even before pregnancy, have a higher chance. Renal disease or kidney problems also increase the risk of preeclampsia. The kidneys help in regulating blood pressure and filtering waste from the blood. When the kidneys are already diseased, they cannot function properly during pregnancy. This leads to high blood pressure and protein leakage in urine, which are key features of preeclampsia. Finally, obesity is an important factor as it affects blood pressure and metabolism. So these conditions increase the risk of developing preeclampsia during pregnancy. Now let us see about the pathophysiology of preeclampsia. The process starts with abnormal placentation. In early pregnancy, the placenta does not develop and attach properly to the uterine wall. This abnormal development is the first change that triggers the disease process. Next, there is failure of trophoblastic invasion. The placental cells do not invade deeply into the maternal blood vessels. Because of this, the blood vessels remain narrow instead of becoming wide and flexible. Due to these narrow blood vessels, uteroplacental blood flow is reduced, Less blood, oxygen, and nutrients reach the placenta. The placenta becomes stressed and releases harmful factors into the mother's bloodstream. These substances cause endothelial dysfunction. This means the inner lining of the mother's blood vessels gets damaged and cannot regulate blood pressure normally. As a result, vasospasm occurs. The blood vessels constrict, leading to reduced blood supply to vital organs. This causes ischemia, which means decreased oxygen supply, and over time leads to organ damage. Finally, capillary permeability increases. The small blood vessels become leaky, allowing fluid to move into tissues, causing edema. Protein also leaks into the urine, resulting in proteinuria, which are key features of preeclampsia. Now let us see the classification of preeclampsia, starting with mild preeclampsia. In mild preeclampsia, the blood pressure is raised, but it is not very high. The blood pressure is 140 by 90 millimeters of mercury or more, but it is less than 160 by 110 millimeters of mercury. There is protein in the urine, but in a mild amount. The urine protein is 300 milligrams or more in 24 hours, which shows kidney involvement, but it is not severe. There may be minimal edema, meaning mild swelling, usually seen in the feet or ankles. This swelling is not severe and does not cause much discomfort. Most importantly, in mild preeclampsia, there are no severe symptoms. The woman does not have severe headache, visual disturbances, epigastric pain, or convulsions. So mild preeclampsia is a condition with moderately raised blood pressure, mild proteinuria, minimal edema, and no severe warning signs. But it still needs regular monitoring to prevent progression. Now let us see severe preeclampsia, which is a more dangerous form of the disease and needs immediate medical attention. In severe preeclampsia, the blood pressure is very high. The blood pressure is 160 by 110 millimeters of mercury or more, which can seriously affect the mother and the baby. There is severe proteinuria. The amount of protein in the urine is 5 grams or more in 24 hours, or it shows 3+ or more on urine dipstick test. This indicates significant kidney involvement. Oliguria means reduced urine output. In severe preeclampsia, the urine output is less than 400 milliliters in 24 hours, showing that the kidneys are not functioning properly. There may be cerebral or visual disturbances. The woman may complain of severe headache, blurred vision, flashing lights, or even temporary loss of vision due to reduced blood supply to the brain. Epigastric pain is pain felt in the upper abdomen, especially on the right side. This pain occurs due to liver involvement and is an important warning sign of severe disease. Pulmonary edema means fluid accumulation in the lungs. This leads to difficulty in breathing and is a life-threatening complication. Thrombocytopenia means a low platelet count. This affects blood clotting and increases the risk of bleeding. So, severe preeclampsia is characterized by very high blood pressure, severe organ involvement, and serious symptoms, and it requires urgent and careful management to prevent complications. Now let us see the maternal clinical features of preeclampsia. Headache is a common symptom and occurs due to high blood pressure affecting the brain. Blurred vision happens when raised blood pressure affects the blood vessels of the eyes and brain. Edema is seen as swelling of the face, hands, and feet due to fluid leakage into tissues. Sudden weight gain occurs because of fluid retention in the body over a short period. Epigastric pain is pain in the upper abdomen and indicates liver involvement. Reduced urine output occurs due to impaired kidney function and reduced blood flow to the kidneys. Now let us see the fetal effects of preeclampsia in a simple way. Intrauterine growth restriction means the baby does not grow properly inside the uterus because it does not receive enough oxygen and nutrients from the placenta. Oligohydramnios means there is less amniotic fluid around the baby. This happens due to poor placental blood flow and reduced urine production by the fetus. Placental abruption is the early separation of the placenta from the uterus. This suddenly reduces oxygen supply to the baby and is a serious complication. Prematurity occurs when the baby is born before term, either naturally or because early delivery is required to save the mother or baby. Intrauterine fetal death may occur in severe cases when prolonged lack of oxygen and nutrients affects the survival of the fetus. Now let us see the investigations done in preeclampsia. Blood pressure monitoring is done regularly to detect high blood pressure and to see if it is increasing or under control. Urine albumin test is done to check for the presence of protein in urine, which indicates kidney involvement. Complete blood count is done to assess the overall blood status of the mother and to detect anemia or infection. Platelet count is checked because preeclampsia can reduce platelet levels, increasing the risk of bleeding. Liver function tests are done to see if the liver is affected, especially in severe cases where liver enzymes may be raised. Renal function tests are done to assess kidney function by checking values like urea and creatinine. Ultrasound examination is done to assess fetal growth and the amount of amniotic fluid around the baby. Doppler studies are done to assess blood flow in the uterine and fetal vessels and to detect placental insufficiency early. Now let us see the medical management of preeclampsia, starting with the general measures. Hospitalization is advised, especially in severe cases, so that both the mother and baby can be closely monitored and complications can be detected early. Bed rest is recommended, preferably in the left lateral position. This position improves blood flow to the uterus and kidneys and helps in reducing blood pressure. A balanced diet with adequate protein is important to maintain the mother's nutrition and to compensate for protein loss in urine. Salt restriction is not routinely advised for all patients. Salt is restricted only when indicated, such as in cases with severe edema or hypertension, and as advised by the doctor. Now let us see the drug management of pre-eclampsia explained in a simple classroom manner. Antihypertensive drugs are given to control high blood pressure and prevent complications. Methyl Dutta is commonly used because it is safe in pregnancy and helps in gradually lowering blood pressure. Labetalol is another commonly used drug. It works quickly and is effective in controlling high blood pressure in moderate to severe cases. Nifedipine is also used to lower blood pressure by relaxing blood vessels and improving blood flow. Anticonvulsant drugs are given to prevent seizures. Magnesium sulfate is the drug of choice. It is used to prevent and treat convulsions in severe preeclampsia and eclampsia and is very effective when given with proper monitoring. Definitive treatment of preeclampsia is delivery. Once the fetus and placenta are delivered, the disease process gradually resolves. The timing of delivery depends on the severity of the condition and the gestational age of the baby. Now let us see the nursing management of preeclampsia, starting with assessment. Blood pressure should be monitored every 4 to 6 hours to detect any rise and to assess the severity of the condition. Urine output should be checked regularly, along with testing for protein in urine, to assess kidney function. Daily weight is recorded, and the presence of edema is assessed to identify fluid retention. The nurse should carefully observe for warning signs. Headache should be noted, especially if it is severe or persistent. Visual disturbances, such as blurred vision or flashing lights, should be reported immediately. Epigastric pain should be taken seriously, as it may indicate liver involvement and worsening of preeclampsia. Now let us see the nursing interventions for preeclampsia in a simple way. The mother should be kept on bed rest, preferably in the left lateral position. This position improves blood flow to the uterus and kidneys. Intake and output chart should be maintained to monitor the amount of fluids taken and the urine output. which helps in assessing kidney function. All prescribed medications should be given on time and as ordered by the doctor to control blood pressure and prevent complications. When magnesium sulfate is given, the nurse must closely watch for signs of toxicity. The respiratory rate should be monitored and should not fall below 12 breaths per minute. Deep tendon reflexes should be checked regularly, as reduced or absent reflexes indicate magnesium toxicity. Urine output should be monitored, because reduced urine output can increase the risk of magnesium accumulation. Seizure precautions should be maintained to prevent injury in case of convulsions. A calm and quiet environment should be provided, as noise and stress can trigger seizures. Thank you for watching this video. If you found this video helpful, please like it, share it with your friends, and leave your doubts or feedback in the comment section. Do not forget to subscribe to the channel and press the bell icon to get notifications for more nursing and medical videos. Thank you.